Hey, today my video is more specific to healthcare providers who may be interested in prescribing buprenorphine for opioid use disorder. So I just kind of wanted to go through my usual steps and evaluation of patients and to see what might be helpful for you guys. So generally speaking, patients are either referred to me by a provider or they call me themselves, and sometimes a family member or whatever. So there's lots of ways that people can come into my universe, and I always talk to patients about starting buprenorphine before they come in. So I give them a quick phone call. It usually is pretty brief, where I get a sense of what their urgency is and whatever. For some people, they're ready to come in that day. The last patient I started on buprenorphine, I called them in the morning. I saw them in the afternoon. I just happened to have an open spot. But if you're scheduling a week or two out, your no-show rate is going to be very high, because people are generally relapsing, or they're just so disorganized that they can't get in. So my strong recommendation is to get them in that day or the next day. Then your no-show rate is pretty low. So on the phone call, I usually ask, if you've been on buprenorphine before, what's your story, what are you using, how many days of whatever do you have, when do you need to come in, what's your insurance, do you need a referral. I kind of get all that figured out. I look at my schedule and I transfer them up to my scheduler, and I say, okay, put this person in for later today at 3 o'clock, or whatever the deal is. And so that's the initial evaluation, and they come in, and we always do a point of care urine drug screen to see what's going on. Then the PDMP report, we pull that as well. To see what they've been prescribed in the recent past, and that kind of stuff. And for the most part, when people come in, they tell me exactly what the other evidence shows, what they've been using, etc. But this is just to check and make sure that we're dealing with what we think we're dealing with. And so then I sit down and I do a very standardized interview. I have an interview that I have used for years, where I go through their current social history, and then their history of chemical dependency treatment, and then their lifelong history of substance use, and some other things. We talk very little about their other medical problems, other than just note that they're in there, or just so that I know what's going on, what other pain they may have, that kind of stuff. But yeah, it is like basically a comprehensive H&P, or just history, not that much of the physical. I will look to see if they have track marks and that kind of stuff, to see what's going on with that. And oftentimes there's some referral paperwork from a physician that gives usually a very limited history of what the concern is, or what have you. So then the critical part of this whole thing is I only have so many minutes. I've got at most half an hour or 40 minutes to kind of make sure that we're on the same page, which is one of the reasons why I make these videos, is to make sure that when people are in the office, if I forget to do something, that hopefully they have an opportunity to access my other thoughts and the framework. But so usually after I take the whole history, I'm very careful to never use the term addiction or addict, or what have you been addicted to before, that kind of stuff. I only use the term chemical dependency. And so the first thing that I do, I kick back in my chair and I ask them, since we started talking, how many times have I used the word addiction? And of course it's none at all. And I say, and that is purposeful. Number one, that people who suffer with chemical dependency already feel bad enough about themselves. They don't need me contributing to their negative inner dialogue and poor self-esteem by using terms like addict, which it doesn't feel good, But I said, even more important than that is this idea that when you tell somebody who is using, for example, alcohol, that you're addicted to alcohol, I say that their inclination is to focus on the alcohol use, where if you tell somebody that they're emotionally dependent, that the chemical dependency is an emotional dependence on alcohol, hopefully they think to themselves, I got to get a different coping mechanism. I need to work on, stress relief, etc., in a non-chemical method. That emotional dependence I need to work on, and that is the critical framework that helps me move to the next point. I'd say the most important thing that you'll hear from me is that buprenorphine is not recovery in a pill or recovery in a bottle. I say that buprenorphine will control withdrawal and it will reduce craving a little bit, but most of my patients who relapse on opioids have buprenorphine in their possession, and they'll have even a full bottle of it, but it just doesn't do the same thing that heroin does. It doesn't give you the emotional escape and the relief and the feeling that regular full agonist opioids do. And so that's the reason why people relapse, even though they already have Suboxone or buprenorphine in their possession. So I do a little more education. I say in your brain and all over your body you have nerve cells, and those nerve cells communicate with neurotransmitters, and the neurotransmitters land on different receptors like dopamine and GABA and glutamate and whatever, all these receptors, serotonin, that may have heard of before. I say the receptor we're interested in talking about today is the mu receptor, MU. That's one of the opioid receptors, and that normally it's stimulated by endorphins and enkephalins from your brain, that if you win a prize or have sex or exercise or whatever, it stimulates that gently and you have the sense of relaxation or whatever. But a few thousand years ago, somebody found that if you took the juice out of the opium poppy pod, the juice has morphine and codeine and thebaine and some other chemicals in it, and that stimulates the hell out of that mu receptor. Now, a few thousand years ago, of course, they didn't know about the mu receptor, but it stimulates it so hard that your nerve cell, which I show as my fist, doesn't like it. And so it actually makes it a little bit harder to get 100% stimulation by making more receptors, which technically is not actually what happens, but for the purpose of this educational thing, it simplifies the whole process quite a bit. So you get more receptors, you need more opioids to have the same effect. You get more receptors, you get more receptors, you get more receptors every few weeks, a few months. With continued opioid use, you get more tolerant to the effect, and to get the same effect, you have to use more and more opioids. And if you take them all away, then all these empty receptors are freaking out, and you have withdrawal. Okay, and many of them are like, oh wow, that makes total sense to me. Okay, I get it. And then I say buprenorphine, which is made from thebaine, which comes straight out of the opium poppy pod. And so normally, the thebaine is converted into oxycodone or buprenorphine. These are semi-synthetic opioids. And so I tell them that oxycodone and buprenorphine structurally are very, very similar because they're both derived from thebaine, which is derived from the opium plant, the opium poppy. And the buprenorphine, though, is a little bit different than oxycodone. Oxycodone stimulates the hell out of that receptor. You get more and more receptors. Buprenorphine, it binds to the receptor and stimulates it gently. So over time, you have less receptors. You can reduce the dose, reduce receptors, reduce the dose, reduce receptors, reduce the dose, and you can get back to a normal number of receptors and gradually reduce the dose without ever going through withdrawal. And so then I talk about how buprenorphine was initially introduced in the world market, I think in the UK, as Temgesic back in 1983. It was taken off the market because it wasn't very popular, and reintroduced in 2003 as Suboxone in the US market for chemical dependency treatment. But it's also now, again, FDA approved for pain, because a lot of the people have some sort of pain that they are worried that they won't have adequately treated on buprenorphine. So I get right ahead of that. I'm like, buprenorphine has always been and always will be a powerful opioid pain reliever. It was only after the fact in 2003 that we started using it for chemical dependency. It was first used as an opioid pain reliever called Temgesic. So, and then we kind of get a sense of, what they are using. Probably 75% of the patients I'm seeing nowadays are already familiar with Suboxone. And I asked them, well, how much did you use? And was it effective? How many days did you use it? If they just used it periodically and not for that many days in a row, they may not have a good sense of how much they actually need. Because, even partial relief from withdrawal with underdosing buprenorphine is going to seem like that was pretty good. But that's all relative. Compared to where they want to be and feeling totally normal, it may not be enough. So somebody may say, well, I used, half of an 8 just to, kind of get out of withdrawal. But after you hear about, what they've been using, you're thinking, oh man, much more than that would be reasonable. I'm a strong advocate for relatively high initial dosing of buprenorphine. That somebody should be on a minimum of 16 milligrams of buprenorphine most of the time if they have sufficient opioid tolerance to support that dose. The reason for that is because it substantially blocks their opioid receptors, so that immediate use of opioids is not very rewarding, and it also takes quite a while to get out of their system. So, and they can reduce the dose eventually. I usually tell people that I expect them to be on buprenorphine for a minimum of 6 months, and that, they probably will stay at the same dose as the starting dose for a minimum of 3 months to get into a recovery program, getting back to the idea that buprenorphine is not recovery. Going to intensive outpatient program or seeing a certified substance abuse counselor or whatever, that's typically the important part of the work, and the buprenorphine just allows them to do it comfortably. It is not by itself recovery. I also say that AA and NA meetings typically are what I would refer to as aftercare, that very few of my patients do well only going to AA or NA meetings, because you don't have that time to work with an individual counselor and talk about, okay, what are your triggers for relapse and what new coping mechanisms that you can use to replace the effect that you're getting from the opioid. The camaraderie and the feeling of being part of a community that's all working together for sobriety is really important. And I really believe that group meetings are very helpful for that. But most intensive outpatient programs, the best programs, have a combination of group interactions where they support each other and learn from each other and feel part of a community, plus individual therapy where you can work on individual coping mechanisms and individual problems that you probably do not want to divulge, or there's not an opportunity to do that in front of a group for the group sessions. And so I strongly recommend that my patients go to a intensive outpatient program. Now there are 4 intensive outpatient programs currently on Kauai, on the island of Kauai. There's McKenna Recovery, and of course Dr. McKenna also works there, so he can prescribe buprenorphine, plus they have a very well-established intensive outpatient program. There is Ahu Vai Vai, which has meetings that are with a certified substance abuse counselor, both in Lihue and in Kalaheo, and Remy is the leader of that program, and her daughter is the other counselor that does the Lihue meetings, last time I knew. The other program is through Child and Family Services. It's called E'alaho. Historically, it's been a program for young mothers and women with children. But about 2 years ago, they expanded and now have a group for women who are 50 years and older, a men's group, and then the young women's group. And then there's also Women in Need, or also known as the WIN House. The WIN House has sober living for women who are either with or without children, but they also have their meetings for group sessions and individual counseling for women and men. So I actually have a sheet that I give out with these 4 programs on. Of course, there's a bunch of residential programs. Residential programs are typically something that take weeks, if not months, to get into. And so, it takes some time to get a bed and then to do the paperwork, and they need a physical exam and, et cetera, to get in there. So I'm usually like, okay, well, if you want to do a residential program, get started on buprenorphine, get in an intensive outpatient program where we work on the paperwork, and then you go to residential. But most people are like, no, I'll just wait till I get to residential. I'm just like, well, what do you wait? Like, do you want to fix this problem or not? Anyway, so there's some strange dynamics, that people go through internally as they're trying to, figure out what they're going to do. But regardless, that's the story. So I usually prescribe 5 to 7 days of buprenorphine based on the dose. And so, when people are using high doses because of the dose response curve of buprenorphine, usually I use for every 90 to 100 milligrams of oxycodone that they're using a day, I would give 1 8 milligram buprenorphine, because that's just my experience of what's necessary. If they're taking much lower doses, then you're going to use a different conversion, which is every 1 milligram of buprenorphine is equal to 40 milligrams of morphine. Now, when people are using heroin, it's really hard to make that conversion, because you don't know, what's going on with it and how potent it is. And I'm not very good at the grams per milligrams of grams of heroin to milligrams of buprenorphine transition. But if somebody's smoking or shooting heroin, they're virtually always highly opioid tolerant, and shooting for that like 16 to 24 milligram dosing is typically, my goal. And you have a few days to work on it. If they're like, well, that seems like a high dose, I want to, start at, 2 or 4 milligrams, I would strongly recommend that you say, okay, but I'm going to give you enough to take a lot more than that. And then we'll see how it goes in 5 days or 7 days or whatever. And most of the time, people's dose quickly escalates. And I'm not exactly sure what the story with that. I'm fine with it because I want them substantially blockaded. I want their opioid receptors highly saturated with buprenorphine so that they're not in withdrawal, they're not craving. If they do relapse, which is almost 100% certain that your patient will relapse within the first several months of treatment, they just, the day one, they don't have the coping skills. How would you can't expect them to be a pro player the first day of training, and so, yeah, they'll get there, they'll get the skills and whatever, but you have to be tolerant to relapse. If somebody comes in every single time and they're positive for opioids, I mean, well, are they going to treatment? Is the dose right? Like, are they able to afford their medicine? Like, what is going on? Try to problem solve with them as opposed to try to, find some reason to kick them out of the program. There's very few patients in my 14-year history that have asked to leave the program. Usually it's like being abusive to the staff or throwing chairs in the waiting room, or I know for certain that they are not taking their buprenorphine because I've tested their urine and sent it off to a lab. And I also have been told by a reliable source that they're selling their buprenorphine. That has happened a few times where they come in and there's buprenorphine in the urine sample and they send it off and it's all pure buprenorphine. There's no norbuprenorphine in the urine. That's what happened. You should have some metabolized buprenorphine in the urine. So what happens is people just crumble a little bit in there. It tests strongly positive for buprenorphine. So if you have concerns that your patient is not taking the buprenorphine and is taking it and selling it or whatever, I mean, that would be one of the few reasons to ask somebody to leave the program. But just relapsing, which is, I mean, it's a chronic relapsing disease. Relapse in itself should never be a reason to discharge somebody from the program. It's a reason to have them come in more often, or adjust the dose, or to revisit, what kind of recovery work they're doing or whatever. But don't be surprised that a chronic relapsing disease is chronic and relapsing. So that would be my advice in general. So the video is kind of going long here, but the key part of the training is to have somebody that you trust and that you can call. I had Dr. Meredith, Charles Meredith. He's an addiction medicine fellowship trained psychiatrist that I went to medical school with. This was all his idea. We hang out, our families have vacationed together a number of times. And years ago, 14 years ago, I was lamented to him, I don't know what to do with these patients who were seeing me that had opioid use disorders in this small town in Alaska. And he's like, get your Suboxone license, you do it. And I was like, oh, I guess it is my job, and it's really taken over a lot of my career. I spend a lot of my hours at work working on chemical dependency issues, and a lot of my kind of free time advocating after work and whatever. So it's been very rewarding for me, and it's really taken over my career. And I honestly had no training in residency, and B, no inclination that this was going to be where my career arc was heading when I started this whole process years and years ago. But you do know somebody, you know me. And so, call me, email me, text me, whatever, 24/7. I'm always very grateful, and I make a special effort to thank the ER doctors who call me when I'm not on call and say, I got this person, how do we get this worked out? Because, they've been in the ER X number of times, or they want to start on buprenorphine and it's Saturday night, please, I don't mind it at all. Just call me anytime with questions about dosing or what's going on with this patient. This patient's complicated, or this is, whatever, any question whatsoever. When you do write your buprenorphine prescription, make sure that in the comment section you put your DEA, your ex-DEA, and then also you write opioid dependence. If you're prescribing buprenorphine for pain, then you would write for pain. Otherwise, the prescription will get rejected by the pharmacist. Typically, Safeway Pharmacy also wants you to write in the numerical or the text of the number. So if you're prescribing 20, you'd write in the text 20 instead of just the numerical version for whatever reason. So all the pharmacies are a little different in what they require. So that is how I go through from my first interaction with patients over the phone to my initial interaction with them, and how I evaluate them, some of the initial education that I do, and then dosing and some other things. I certainly educate them that buprenorphine is destroyed in your stomach and by your liver. I try not to use the phrase first pass metabolism, but just for you healthcare professionals, buprenorphine has a very high level of first pass metabolism. If you swallow the pill, or you swallow your saliva with a lot of buprenorphine still in it by not letting it dissolve and be absorbed into the capillary network underneath your tongue. So if you swallow fairly soon after it dissolves, all of it gets absorbed into the portal system. It goes through the liver pretty much annihilates it. Where if you put it underneath your tongue and it's absorbed into the capillary network, it goes down your jugular to your heart pumps it out, it goes all over your body. I mean, some of it will go to your liver, but by and large, the vast majority does not go to your liver, and it goes to your brain and your peripheral tissues where the buprenorphine can access the opioid receptors, and it works great. So I say no talking, no drinking, no spitting, no swallowing, no eating, no nothing. You put it underneath your tongue, you drink a little bit of water if you have a dry mouth, so your mouth is wet. Then as long as you have enough, because a lot of people say it doesn't dissolve, and it turns out they're on like some anticholinergic or something like that, where they just have dry mouth, or they're a smoker or something. So make sure that their mouth is wet. You put it underneath your tongue, a minimum of 20 minutes. Initially, when they start out, I have them spit their spit, because a lot of people, if they swallow their spit after the 20 or 30 minutes of letting their spit sit in their mouth, they're a little bit nauseated. And so initially for the first few doses, have them spit their spit, and then if they want to after that, they can swallow it, and see if it makes them nauseated. For people who are IV users, I typically try not to use the straight buprenorphine. I have had patients shoot up, Suboxone. I have had patients shoot up Suboxone too, which makes no sense to me, but whatever. But to shoot up the plain buprenorphine, also known as Subutex, so that is a concern. I would, if somebody says, I've been on Suboxone before and it makes me sick, I don't want that to be a barrier to them if, a lot of people have headaches or nausea or whatever because a little bit of the naloxone does get into their system because they got like poor dental hygiene or whatever. Even though very little is supposed to get in there, some people just whatever, it doesn't work for them. If they have active track marks later, I'm going to take them back off, and so, I just, I'm pretty careful if somebody has a history of IV use and I'm giving them plain buprenorphine, they be cautious, go ahead and do it, monitor them carefully. Typically, if somebody's using intravenously, they will run out early and they have active track marks. And if that's the case, then you're like, you're off, I'm putting you back on, Suboxone or the films, or we're doing the shot or something. The subblockade. Subblockade, you got to be on buprenorphine stable, at least 8 milligrams a day for 7 days. And it's very expensive, but it's a very helpful option for people. So that is prescribing buprenorphine 101. And thanks so much. And, please feel free to get in touch with me. I'm easy to find. Have a great one. Thanks.